Okay. All right, do people see our slides? Because right now all we see is us looking funny on the camera.
I'm just trying to make sure. I'm looking at another screen, so let's see here.
Okay.
See screen sharing. Clear my phone.
If it helps, Art, I can see their slides as well as their funky video, but we can definitely see their slides.
Okay. Okay.
Okay. Thanks, Kat.
All right. So while we do our PowerPoint, Art, if you advance our slides for us, maybe you can work on getting rid of that virtual background because it'd be nice for us to be able to show everybody the simulations we planned.
Okay.
Great. Thanks. All right. So we're going to go ahead and get started. My name is Mary Fay. I'm one of the neonatologists here at Albany Med, and I'm the medical director for the neonatal intensive care unit. This is Cheryl Dunton.
I'm a nurse clinician here in the NICU. I've attended thousands of births, so we have some significant experience with neonatal transition after birth. So we're hoping to be able to share some of our tips and tricks with you.
So this actually was prompted by some real live cases that have happened in the last couple of years of infants born out of the hospital, and several people reached out looking for this talk. So we're very excited to be here with you all. So this is the unanticipated delivery. And the title is Plastic Wrap is Not Just for Cookies. Yes, we use saran wrap in our DR, and we want you all to consider saran wrap as a heat source for neonates in the field. So we're going to go through some cases about the immediate care of newborn outside the birth center. Next slide. Great. So I think the most important thing for you all to remember is within 30 seconds, most neonates will begin breathing on their own. It'll take an additional 10% of those babies to, sorry, I'm just moving that, to begin to breathe with some drying and stimulation. Only about 5% of neonates will require positive pressure ventilation, or what we call PPV, to begin breathing on their own. Next slide. So we really want you to think of newborns as a totally different animal than adults. We know that you all do adults very well, and you do chest compressions and ventilation, you use defibrillation, but neonates really, their main goal for them is ventilation, ventilation, ventilation. When they're first born, their lungs really are not full of air, and they need to get through that transition period. So infants will go into respiratory failure if they're not initiated, or we cannot maintain effective breathing effort for them. And this is our big Bible for us is neonatal resuscitation. Right now we're on our 8th edition. Go ahead, next slide. So the second most important thing besides ventilation is thermoregulation. I know it may seem weird, why not are we focusing on the heart? Cold stress is a big issue for babies. So if the minute they start to get cold, it increases their mortality and their morbidity. There's a 28% increase in mortality for every degree Celsius lost. We know that neonates will lose 2 to 3 degrees Celsius in the first 30 minutes. And a lot of this has to do with their large surface area to body ratio, but you can see there's other factors as well. Go ahead, next slide. So when they do get cold, what happens to them? They have worsening hypoxia as the temperature drops. They become hypoglycemic. They have worsening respiratory and metabolic acidosis, which then leads to cardiovascular compromise. So oftentimes when we get these babies from outside, they're bradycardic, and people are freaking out. Oh my gosh, their heart's going to fail. It's actually, they're bradycardic because they're cold. So then they have worsening hypotension and then decreased perfusion. Most importantly, though, neurologically, these babies do not do well after they've had major cold stress. The neonatal literature really has a lot of good data that shows that is one of the most important things that we can do for these babies is to keep them warm. Next slide.
So from a practical perspective, as Dr. Fay has mentioned, cold stress can absolutely make your work of resuscitation much, much harder. So we're hoping to give you some interventions to assist with thermoregulation for every newborn. And this is newborns, this is exactly what we do in the hospital as well. So certainly it's prime importance when an infant is born outside of the hospital or birth center. We're going to dry these babies quickly and remove that wet linen. So we usually have 2 or 3 warm blankets to just dry the baby and throw them aside. Plastic wrap. We use saran wrap on the head and body and then cover them with a warm blanket everywhere except the face, and maybe leave a little bit of the chest open so that you can actually see that this baby is making good respiratory efforts. As I said, warm blankets is super important. We actually have a warmer in labor and delivery that we get our blankets from. If you're not in labor and delivery or in a hospital, how can you warm a blanket if you know that you are attending a birth, and certainly a preterm birth? Can you warm a blanket or a shirt or a towel or a kitchen towel near a heater, maybe the heater in the rig, or if it's, in a delivery in a car, maybe a family's car, is there a heater in the car? Definitely turn up the heat in the car. Can you put a blanket under your coat or on mom's chest to warm up a little bit? And then certainly skin to skin is something that we should consider. If this baby is born after the cord is clamped, the baby's breathing fine, even if it's a little bit premature, if we can get this baby skin to skin with mother, and that's complete skin to skin contact on top of saran wrap, so no clothes or blankets in between, that's going to be the biggest thing that you can do to help with thermoregulation. Next slide, please. So initial steps after birth. These steps are all done relatively quickly and with every single birth. It really is regardless of gestation. We start these initial steps every time. The goals are always both in-house and out to maintain support for thermoregulation and establish effective ventilation. Next slide, please. The strategies to manage these babies, as I said, is the same, whether we're doing it inside or babies that are born not in an anticipated way outside of a birth center or hospital setting. Temperature management is right at the top of what we try to focus on a little bit. Clearing secretions we're going to talk about. We're going to talk a little bit more about positive pressure ventilation here. And then assessing heart rate, what's the best way and how. Oxygen management is an area of just an area we're going to touch on. Alternative airways and vascular access and medications, we're just going to touch on, but we're not going to cover comprehensively here. And then we'll talk about chest compressions. Next slide, please. All right, as Dr. Fay has mentioned, we use neonatal NRP as a guide for our practice in helping these babies transition after birth. The 8th edition is what we use. It came out last year, I think we switched over. This part of the algorithm is going to be most helpful for births that occur outside of a birthing center. Warm, dry, and stimulate, as you can see outlined in the red box. That's with every patient. And then position the baby, position that airway to optimize chances of the baby being able to effectively breathe, and then suction only if needed. Just a word about suctioning. We don't aggressively suction in the delivery room anymore. We did for years and years. What we realized is we can actually bagel these kids and again, kind of hurt our own efforts by not allowing the baby to naturally try to clear the secretions. If the baby has a lot of blood or a lot of fulminant secretions bubbling out of the mouth and nose, we're going to take care of those. After we've done that, we're going to see where this baby's breathing is. If he's breathing effectively, great. We're going to let him continue and make sure that he's warm. If he's not, we're going to go on with some assistance with respirations. So this is a good piece of the algorithm to focus on. Next slide, please. All right, for every baby, how do we keep them warm? So right after birth, the cord is clamped, the infant is then dried, and those wet blankets are removed. We're going to go through these in our scenarios as well, but probably the point in all of this is we go through these steps relatively quickly and pretty much in the same order with almost every birth. So the infant is dried, the wet blankets are removed. We pretty quickly cover the head and body with plastic wrap for all of our preterm and late preterm infants, even in the hospital, so certainly outside of a birth center. And then cover the head that's now got saran on it, either with a hat or a towel or a washcloth, a dish towel, a shirt that's nearby, something, and then cover the body also with a towel or blanket, leaving the face exposed and only enough chest to see that chest rise. Next slide, please. Secretions. We talked a little bit about this already. We're only going to remove those secretions if they're actually occluding the airway. I don't know if you can see, can you see us on camera yet?
No, it's still got the virtual background that's blurred.
Okay. All right, so we're gonna only remove those secretions if they're occluding. We use a bulb syringe, and to use a bulb syringe, as you can see on the screen, you depress it first, and then go down the side of the mouth. So you're going down the cheek side versus straight back. I remember a delivery where the APGARs were like 8, 1, and 8. And that was completely because I used a deep suctioning technique and actually vagaled that baby's heart rate. So you really can vagal them. They're pretty sensitive when they're born. So if you go down the sides of the cheeks, you're less likely to cause that kind of reaction. So you place the depressed bulb syringe in the side of the cheek, depress, allow it to fill, and then take it out of the mouth and squeeze it out. And we do that for both sides of the mouth and then both nares. DeLee or suction catheters, I think you also have available to you. We only use those really routinely for large amounts of secretion. So again, if there's an abruption or, and the baby just has a ton of blood or really, really thick secretion. Some of our babies that are born with bowel obstructions have a lot of bilious secretions or bilious emesis or aspirate in their stomach. So we will suction or empty their stomach using those catheters. Otherwise, we really just stick to the bulbs. We're going to stimulate respirations by gently but firmly rubbing the infant's back. We're not going to spend a lot of time on this. You know, we're not going to rub and rub and rub and rub and eventually he'll breathe. We're going to not delay beginning PPV. Sometimes if you can just get the baby's lungs to begin to expand, it makes the successive breaths easier for that baby, and you may not need to go further. So if the baby does not begin breathing immediately, we're going to proceed to PPV. Next slide, please. All right, positive pressure ventilation. What you need for that is an appropriate size mask. And I think what you have available to you right now is small, and that's a newborn size. That's likely what you're going to need for a newborn infant. Just keep in mind that may be a little bit big for some of your very preterm infants. So that may be a challenge in actually achieving a good seal of the mask to be able to ventilate really, really well. And then you need a self-inflating bag. The self-inflating bag will give 21% oxygen unless you're hooked to a tank. If you are hooked to a tank, realize that you're delivering 100% oxygen generally to these babies. And that's not necessarily what they need. They need the mechanical ventilation at first. We start all of our resuscitations here generally with 21% unless the baby's extremely premature. All right. So we're going to stand at the baby's head. We were hoping to be able to get a little camera time for some action here, but stand at the baby's head and we're going to make a C with your fingers and roll the mask from the infant's chin up to the bridge of the nose. So if you can see the way that the hand is positioned in the picture on the slide, you can see the 3 fingers on the chin and into the neck. You want to make sure that you're not occluding a soft tissue in the neck, and the mask should be positioned firmly on the chin, not below the chin, or you're not going to seal well, and not so high that it's up on the baby's eyes for the same reason. You're not going to be able to seal well. Okay. Gentle head tilt, and we can't really probably talk about this quite enough. Babies, when they're first born, their airway is very, very tenuous still. So a little over and a little under extension can make all the difference. So if you can't initially ventilate the baby, that algorithm is going to help you to remember to reposition the head. Gentle squeeze of the bag is also what we're looking for. These babies don't require a lot of volume in their lungs. So it's really a gentle squeeze of the bag for each breath to achieve a gentle chest rise. And that cadence is breathe, 2, 3, breathe, 2, 3, breathe. It's much slower than most of us tend to do when we're in an anxiety-provoking resuscitation. So I tend to do that. I had somebody teach me years and years ago about CPR breathe rate is kind of like a waltz. So it's that breathe, 2, 3, breathe. I tend to do that in my head when I'm resuscitating a baby. So, all right, next slide, please. Okay.
Dr. Faye,
Yeah.
can I just interrupt you for a minute?
Yeah.
Can either you or Cheryl go to the computer and there's where your video button is, there's an arrow. And if you click on that arrow, it'll say choose virtual background.
Yeah.
And then you can click on none and that should fix.
Yay.
Yeah, there we go.
Yay.
Awesome. Yes,
Right.
I can see it now.
Okay,
Yay.
we're still good, right? All right, good. Okay, now you can see us, right? 'Cause we can't see ourselves, so.
Excellent. I'm so glad. So, so now we can demonstrate.
Yeah, now we
some
can,
of the-
so Cheryl talk and I'll be here.
So we're going to demonstrate, first of all, the positioning of the mask, and you can just do the mask, Mary, with your fingers if you want to. Show the C position on the head. All right, so Mary's using her hand to show you kind of, you make that C position standing at the head of the bed, and then roll the mask from the chin up to the nose, and position the mask on the face. All right, if you cannot establish, so then you're going to try a breath or two and say, go ahead and under.
Okay. So the head's like this and we're really not
Right.
getting effective ventilation.
So you try a breath or two, and if you can't establish effective ventilation, can you see the mannequin okay? We can't see it at all, so.
Yes.
Great, okay.
So if you can't see any chest rise after a breath or two, we're going to actually go through this acronym. Mr. SOPA is the thing that helps us troubleshoot when we're trying to establish ventilation. It all seems like a lot of hubbub about ventilation. It truly is. If you can ventilate these babies, we can avoid so many other things. So the first one is M, and that stands for the mask. So is the mask the right size? And is it in the right position on the face? I can't tell you how many times it's up too high or down too low, so air is actually escaping out the side of the mask. So we're going to reposition that first. Try a breath or two. If you cannot get the chest to rise, we're going to go to the R, repositioning the head. As I said, over or under extended. And this baby is not going, you're not going to be able to get air in and out. Okay. If that does not work, and it looks like we've established ventilation, if this were not working, Mary would continue with the secretions with the S. So down the side of the mouth, squeeze it out, and then each snare. And as you can see, these steps are relatively quick, like it doesn't take a lot of time. And go back and try again. And if we've established effective ventilation, you're going to stop there. If you still can't ventilate, you're going to continue to proceed down the steps. O is open mouth. Sometimes babies just require a little bit of open mouth. You can put your pinky in the side of the mouth to just give it a little open. Try again. Again, if you have no response, you're going to move on to the P. P is pressure, so provide a little tiny bit bigger breath. So you're going to squeeze the bag just a little bit harder to get a little better inflation. It could be a hypoventilation issue, nothing with the equipment or your technique, just that the baby's lungs need a little bit more pressure to open. And then the last step is alternative airway. If all of those steps don't work and you're still struggling to ventilate, that's when we're going to think about this baby likely needs to be intubated or an LMA. So you're going to continue PPV until you have someone available to be able to help you intubate this newly born infant.
Okay, go ahead. Next slide.
All right, assessing heart rate. Heart rate may be palpated at the base of the umbilicus.
We have a preterm baby and you can see there's the umbilical cord here. You can just palpate, put your fingers here. Don't squeeze too tight because you could occlude it.
And then if you can't feel anything, but this baby is crying, likely the heart rate is there. Listen, the apical heart rate is definitely the best measure. We're looking for a heart rate over 60 beats per minute. If that's the case, and this baby is either not breathing or not breathing effectively, we're going to continue PPV until this baby is either crying or can't sustain effective respirations. A baby of this size is obviously not going to be able to sustain his respirations very long. A baby of a late preterm or closer to term infant that may have required a couple of PPV breaths or even for a few minutes after birth may transition and begin to start to cry. Okay,
Go ahead.
all right, next slide. Heart rate. So just a talk about a heart rate in these babies and beginning chest compressions. The major difference between this and PALS or the other algorithms for resuscitation that we use is we really focus on effective ventilation. So if this heart rate remains below 60, despite effective ventilation for 60 seconds. So you really need to be certain that you've established effective ventilations before you begin chest compressions in a newly born infant. Ensure that the ventilation has been established. How are you going to ensure that? Chest rise, bilateral breath sounds. And then we also have CO2 detectors that we use here that I don't think are currently part of your repertoire or availability, but they can help you to determine whether you're actually exchanging air. So maybe down the road, that would be something that would be helpful. All right. Alternative airway is almost always recommended when you're headed towards chest compressions. However, if you're still en route to a center and you have not, don't have someone who can place an alternative airway or don't have an alternative airway size that you need, you may have to continue with PPV and begin chest compressions on the way.
Okay, next slide.
Oxygen administration, we're just really quickly through. We've already talked a little bit about, you really don't need to supplement oxygen initially. We start all of our babies at 21%, even our very smallest babies, sometimes 30, but not much more. So if you hook to a tank, you're giving the baby probably 100% that they may not need initially. If the infant remains cyanotic after establishing effective ventilation, or when you begin chest compressions, supplemental oxygen should be used if it's available. Next slide, please.
Okay, so for your alternative airways, we know that most of you that's not a procedure that you normally do. So we don't want you to be attempting this if you're not qualified to do this. NRP is really pushing for outside community hospitals for those who don't have somebody who can intubate LMAs. We do have LMAs. We use them down to about 1,250 grams. You see pictures there on the screen about how they go in. Remember, if you are equipped to do this, remember to deflate the cuff before you put this in the airway. I think of it almost as like a backward spoon. People sometimes panic and want to put it the other way, but remember about proper positioning. A lot of your emergency departments around here, I've been to Samaritan where they've used them, also intubation. But I cannot express to you, remember, like if as Cheryl said, if your heart rate is less than 60 and you are effectively ventilating, meaning you're seeing color change, you're seeing good chest rise, but you're really not having that heart rate come up, then it's really recommended to do an alternative airway before you do chest compressions. The most common reason of resuscitations gone wrong that we see babies come to us for either therapeutic hypothermia or various other reasons is somebody gave chest compressions too soon and they were not effectively ventilating. Remember back from the beginning, only 5% of babies really need PPV. Again, more preterm infants need that, but most term infants, very few babies need PPV. So you can also see some pictures of how we intubate. One of the most common pitfalls of outside emergency departments is the breathing tube is put in too deep and it's right main stem. So if you're part of this procedure and you're helping in an emergency department, remember to, we use 6+1 as our algorithm, and we can talk about that, but that's really beyond the scope of this practice. Next slide. All right, so you can see a few images on the slide. I gave some examples of IOs. I have placed them in emergency departments and the pretibial area for neonates. That's really the most robust region. Again, don't do this if you're not trained to do this, but you can see in the middle of the slide, there's a radiograph of an umbilical venous catheter that's going over the portion of the liver. And you can also see, if you look closely, an umbilical arterial catheter. Those are routinely what we use in the hospital and even in emergency departments. And then on that corner slide, you'll see the umbilical cord, when you cut it, you'll see the vein is actually usually gaping open. And if you're trained to do this, it's pretty easy to find. It slides right in. The arteries, sometimes you have to dilate up, and it's a sterile procedure that's planned. These are our alternative access that we use to give epinephrine and volume. Next slide. So we want you all to know there is a great resource that you can use for NRP. There's NRP skills videos that are accessible on the NRP launch page. You can see the website there. There also is an NRP app, which we've been told is no cost. It has video demonstrations, some cognitive aids, also a 3-minute video about how to go through your Mr. SOPA ventilation corrective steps. Again, Cheryl and I both are instructors here at Albany Med. So if you would like more resources on that, we also have a NICU bootcamp roadshow where we go to other outside facilities and actually run simulations like this. So if you're interested in that, Art can get you our contact information. Or you can just look at the slide because my email is across the slide. Go ahead, next slide.
All right, so now we're going to we kind of did a PPV demonstration already. I don't know if they can see one on camera.
Yep. Are you guys, can you see this, what we're getting ready right now with the baby? Art, if you want to, you can get rid of our slides.
Okay.
And then that'll make us all big.
There we go.
Okay.
Okay.
So we're gonna try and.
We're gonna just try to make this so you can see. I don't think that's gonna be worse. Yep. That's gonna be worse. All right. Yeah, should be able to see that. Okay. So PPV, we talked about what do you need for PPV? You need a mask and you need your bag, and that's essentially all. To ensure or help you determine that you're effectively ventilating. Certainly a stethoscope is something we're going to need. If you have a CO2 detector, that's super helpful, and some suction, just in case you run into those in those steps. But to start, the positioning is best at the baby's head, using that C position with your hand, as Dr. Fay is doing, and then roll the mask up from the chin up to the nose. You're less likely to place it actually too high over the eyes. Okay. I don't know if you can see that.
And it should be just at the top of the bridge of the nose. So it's just covering the baby's top of the nose, and it's just on the chin, and it'll help you get a tight seal. So I'm forming a C. Be careful with your fingers under the neck. You can see my fingers tingling. Sometimes you can actually occlude the arteries under there, and it's not good for the baby. And then you're just going to do a short, small breath. You can't actually see this chest rise in this baby. And you can see I'm only just squeezing the bag. So again, the rate is breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. So actually in my resuscitations, I actually call this out, especially when you start doing chest compressions, because people want to jack that bag going. We get a lot of pneumomediastinum and pneumothoraces from births outside in community hospitals and things like that.
So if you can't get that breath in initially, we're going to, again, go back through those steps. So the Mr. Sopa steps is the mask appropriate and in the appropriate position. So Mary's going to check that. And then if she can't get in, so if she can't get any breaths in, we're going to go on, sorry. And we're going to go to the R, which is reposition the airway. So maybe the airway is just a little overextended or a little underextended. So she's going to reposition that airway a little bit, try the breath again. If she can't get it in, she's going to continue to go down. We're going to suction this baby to the S, down the side.
Also, sometimes people use a shoulder roll that can help in the field. If you're intubating, I caution you though, shoulder rolls in small neonates can actually hyperextend and you'll completely lose your airway. So I caution you with shoulder rolls if you're putting an alternative airway in, but they're great positioning factors to help protect their head. They tend to want to put their chin to their chest.
Also, if you have a baby that has a tremendous amount of molding, a big baby that's, maybe an anticipated home birth.
Right here, it'll force it like this.
Yeah, so it forces that you almost need something for that elongated head to actually rest on. So a chest, shoulder roll is helpful. Okay, and then the next step is the O. So make sure the mouth is open. We're going to try again. If it doesn't work, we're going to increase the pressure, a little bit bigger breath.
So then I'm giving a bigger breath. Our small infants, the really preterm ones, like 24, 25 weeks, we recently had a 27-weeker born. Those babies sometimes need longer eye times and a little bit of a bigger breath at the beginning, but more of a longer eye time at the beginning. Then when you start to see that chest rise, back off and make sure you're just doing some regular small breaths.
Yeah. And that cadence is always breathe, 2, 3, breathe, 2, 3. Your partner, whoever is there with you, can help you determine if you're actually effectively ventilating, and you should have bilateral breath sounds. So, okay. So those are the steps of Mr. Sopa that can help you troubleshoot PPV, which is going to be the biggest gain for any situation with a baby that's not breathing. Okay. All right, now we're going to talk a little bit about what do you need for every single delivery. So, thank you. Every single delivery. So you're cold and mom's giving birth in, on the kitchen floor. So you're going into a birth. You're gonna need towels, right? There may be towels in her home, maybe dish towels, maybe she's got baby blankets, maybe there's clothing around, washcloths, anything that you can use to dry this baby, okay? So we're gonna get ourselves a couple of towels.
And we know your delivery kit has a swaddler. The swaddlers are great when you're all set and done, or if you can't do skin to skin with mom, swaddler and then some blankets. Also, if they have baby blankets, if clothes even, things like that.
All right, so we're gonna have something to dry this baby. We have our towels. We're also hopefully gonna have saran wrap. If you don't have saran wrap, what can you use? If you're in someone's home, maybe use a Ziploc bag.
You can take a Ziploc bag.
A sandwich bag. Maybe you have a plastic bag that your equipment came in. Maybe you opened a brand new Ambu bag and it comes in a plastic bag. You can use any of those
You
things
even
to
put the
help.
baby down into the bag, which is what we do for when there's a baby with a gastrosthesis or an umbilical, just like that. And of course, keeping, obviously not putting anything over the head.
Yeah.
So we're gonna go through what you're gonna do for a delivery and show you how it goes.
Okay. Suction, don't forget your suction. So some sort of suction, and then we have our saran all ripped. Okay. So you don't know much about this gestation except that this baby is supposed to be near term and she's already delivered at home. So you get there, the cord is clamped, and we're gonna now just help this baby transition. We're gonna dry this baby. Wasn't born with a diaper. We just put that on. So we're gonna dry him relatively quickly. We're gonna get rid of that wet linen. Huge step right there. A lot of people will leave him right on that wet linen. He's still on that cold wet linen then. Okay, so
Even if it's term, we want you to use the saran wrap.
Yep.
Because these babies always are cold. So you're gonna put saran wrap on the head and you're gonna cover with anything, a towel, we have a hat, but cover with anything you can on the head. Washcloths even on the head like this, if you can't do that.
all right, leaving enough of the chest open to just be able to determine if this baby is actually breathing. Okay.
Okay.
We see that this baby is breathing. He's starting to cry. Things look pretty good. So we're going to actually get this baby skin to skin with mom. You can have mom sitting hopefully in a chair. Maybe hopefully she's delivered the placenta. If she has not, she's laying down. You can do this with mom laying down as well. So we're going to leave that hat on. We're going to leave the saran on. We're going to take the baby out of this blanket and we're going to put this baby skin to skin with mom. We're not going to make Dr. Faye strip, but it generally would be skin to skin. No bra, no shirt, no blanket between. And then a warm blanket on top. This mannequin does not remove the baby, his head. So normally you would have the baby's
You want to
head.
turn the baby's head to the
Position.
side so you can watch the breathing. You can also ask mom to feel if the baby's breathing. If it's near term and they're upset, they're going to certainly be screaming. But you can just assess the breathing. This is a great way for transporting a baby. Sometimes we see babies come in cold and all sorts of things. If you can get this to happen safely, then that's the best thing to happen.
Beautiful.
All right.
All right, so this baby is now ready to transport to a birth center nearby. All right, now we're going to show you a little bit more with a preterm. Okay. Second, so we're going to get all of those things that we needed for any birth. So we need towels, we need blankets, we need saran, some sort of suction device, a hat, clothing, something if you have it. I think that's it. We're pretty ready.
All right, we're ready. All right, so we're getting a small baby now.
Yep, so you've been called to a decided 90. Mom and dad have pulled over in a vehicle and there's a mom giving birth in the vehicle. You get there and she's giving birth to probably we'll call it 7. This is a very small baby, but 7-month gestation baby. Okay, so we're gonna, as soon as the baby's born, cord is clamped. We're going to do the same things. We're drying this baby gently. We're going to get the baby off some wet linens. We're going to get saran on the body. Sometimes we lay it down right underneath the baby and completely encircle the body.
And you can have somebody, while somebody's doing the body, you can have somebody do the head. So you're doing it real quickly. We talk out loud. We do this a lot. So we sometimes don't talk out loud, but you should be talking out loud. And you're looking for assessing the breathing. You're covering up except just the breathing, the chest.
Yep. So this baby is not breathing. I'm going to give him just a second of stimulation. See if I can get a baby this small. You're unlikely to even have to do that step. A little bit bigger baby. Give him a try. See if he's gonna try to breathe, and then
Not breathing.
absolutely begin.
So we're going to put our mask to our chin and cover our nose. And I'm going to start giving some breaths. In small babies, you can see, I don't know if you can't see this, but just even a small breath, a push of the bag is going to really open these lungs up.
Yep.
So while I'm giving some PPV, I'm looking and assessing to see if I'm seeing chest rise. Cheryl is going to listen and see if she's hearing bilateral breath sounds. Breathe, 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 2, 3, breathe, 2, 3, breathe, 2, 3.
Beautiful. Bilateral breath sounds. We're just going to continue for a little bit here until this baby starts to breathe and can effectively breathe on its own if he's starting to cry. This size baby is unlikely to do that. You're going to have to continue to ventilate this baby.
So she listens to the heart rate and it's 80 and the baby's intermittently breathing. So I'm going to continue the PPV for the baby. If for some reason you had a bigger baby and the baby was consistently breathing and you had a heart rate over 100 and you're doing much better, you can just stop and give CPAP. But most in situations you're in, you're really going to have to probably continue to breathe for these babies.
Okay, hold please. All right, the heart rate is now below 60.
Okay.
So ventilate the baby, please.
Okay, so we're going to go through our Mr. SOPA. I'm going to look at my mask and I'm trying to breathe for the baby.
I have bilateral breath tones. Say we have a CO2 detector on, we have color change. So we have effective ventilation. This heart rate is below 60 at this point. We don't have someone here that can intubate. So we're going to actually begin chest compressions. In a baby this size, thumb on thumb, I don't know if you can see that, we'll do it sideways. Thumb on thumb is the best technique. And it's 1 and 2 and 3 and breathe. 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 You're going to do that for about 60 seconds and then reassess. And it's going to be high.
And while she's checking the heart rate, you want to continue your ventilation.
The heart rate is about 80.
So our heart rate's improving, so we can stop our chest compressions and continue our PPV and effective ventilation.
So when we started chest compressions, what we did miss is if you have a tank, try to remember to get that hooked up to an oxygen tank. As soon as we start chest compressions, that baby could likely use 100% oxygen.
So that was on our slide. Either if your baby's cyanotic or you're starting chest compressions, go up to 100%. We do that in the hospital and we would recommend that in the field as well.
All right, I think that pretty much covers the scenarios that we had anticipated running. And I guess we'll open it up to questions now.
Yep, no, I think that sounds great.
So let's see. And I'm not sure the abbreviation here, but it says, I hope to hear about field HIE management, especially from planned home birth.
Yep, great question. So if you're worried a baby had, let's say, an abruption, or you think this baby is not doing well neurologically and you anticipate this baby needing therapeutic hypothermia, really the only way for us to assess that, we assess it in the hospital. And just for you to know, for those who work at outside community hospitals, we'd be happy to share our algorithm. But when we hear about babies in the outside hospitals, if there's a cord gas, we want them to call us less than 7.1 or cord pH really less than 10. So that's conservative because we want to hear about it. So in the field, you don't have that cord gas. And so what we want you to do is you're going to go through your EMS, call your channels, but eventually we want somebody to call us at the AMC transfer center. You get a neonatologist on the phone right away. We carry these doggles around our neck 24 hours a day. You'll get one of us. We'll have you talk to us about what's going on with the baby. But remember, we talked about cold stress. So we don't want you to keep that baby cold, because a lot of times when people start to try and get ahead of themselves and start to cool babies, they overshoot. And then when you overshoot, that's even worse. So we want you, even if you're concerned about therapeutic hypothermia, we want you to do what we just talked about. We want you to keep that baby warm, because the likelihood of you overwarming that baby is incredibly low. And it's more likely you're going to overcool the baby. So go through your channels, do what we talked about, call the transfer center, get somebody on the phone. And of course, we're the only center in the area that does it. So you'd be bringing the baby to AMC.
Yeah. Make sure the baby's breathing, all those same things apply. So you're going to support ventilation and you're going to likely get this baby relatively quickly to a center.
And so the cooling cutoff is as long as there's no major malformations and the baby is not completely obtunded and we're not dealing with something like a 6.5 cord gas or blood gas, we would cool within 6 hours, ideally. The sooner the better. So that's really the cutoff. If there's other major like trisomy 18 things that can stop it. There are a few other minor contraindications, but we would talk you through that. Hope that answers that question.
There's another one about what are your thoughts on a OPA or oropharyngeal airway in a neonate?
Yeah, so you mean just like an oral airway? We will sometimes use those for Pierre Robin or if there's major malformations. That is reasonable. Sometimes if you were even turning those, if they're stable, you can even turn them supine as you're watching them. If they're on a monitor, that can avoid that. But yes, usually for,
Sometimes we'll put them right on their bellies in the DR. Like if they have a real short jaw where we're concerned that they're going to occlude their own airway, sometimes we'll wait on that oral airway, and just the positioning, prone positioning of the baby will allow the baby to be able to sustain his own airway. So good question. I don't know that I would automatically go to that if this baby can try to breathe on its own. If you can't ventilate, then you're talking a whole different midline issue.
Okay, and then, so all we need is a bump in a heart rate, and then we can stop compressions and go to ventilations?
Correct.
yep. So if you get over 70, if you're over 60, sometimes you'll see us kind of teetering around 65 and then they'll dip down. But if you're over 60 consistently, ideally like 70, 80, you stop compressions and continue ventilation.
And do you check blood glucose on a healthy newborn?
Yes, always. Well, the only caveat would be if you can't do anything about it, like you don't have access,
Yeah.
and the baby's nice and pink and screaming and crying, you might want to not check it until you're in an ED, and then you can either give gel. We use dextrose gel. We know you don't carry it in your ambulance, but you certainly wouldn't want to be giving a baby a piece of candy because you're
So that's a great question though. A baby, that is one of the things that we look at relatively quickly. Any baby that's been in any kind of distress with transition from even a term infant, it has been, is something that we would absolutely monitor.
And beyond ventilation and cold stress, that should be your third vital sign. Agree, as long as you can do something about it.
Yeah, that's a great question.
And then this is from Robbie McHugh at Colony. They added the Aegis neonatal wraps by Saplicor, which have been ambulance crash tested. It keeps the baby warm with skin to skin contact. And it also has a seatbelt adapter to, for expecting moms or moms that have just delivered, so that they're secured. And it's in addition to the Furno Pediamate in neonate. So
that's awesome. That is really great news. Good.
Let's see. What are your thoughts about using one foil infant swaddler with head cover and then the Aegis neonate medical wrap?
Yeah, that sounds fine. Anything to keep them warm. Again, I've never seen a baby too hot. It come in from outside.
So I know that you carry the swaddlers, I think, in the ambulance, and we grabbed one. You certainly can use that on top of saran once you get ready to move this baby after you've removed all the wet linen. Or if this is all you have, then absolutely you can use it for that. But certainly you can tuck the baby down in that with the saran wrap still on, with a hat on, absolutely. This can serve as your blanket for sure.
All right, and then the most accurate place to check a heart rate, is it auscultating the heart?
Yeah, really. We did talk about palpating the cord, but if you can't, it starts to stop pulsating within 3 minutes. So I really actually skip it and auscultate. And just go right, your stethoscopes are pretty big. If you just go right into the middle of the chest, you're going to hear something.
Okay.
And then I just have a plug out. If anybody's interested, we talked with Mike Daly. We know that it costs a lot of money for you all to learn NRP, but you have our emails. We also, Albany Med offers stable, but like I said, we do a NICU boot camp roadshow where we run simulations. We do an airway station with Chad Pisano, and then I review cord management. Again, you wouldn't be getting an NRP certification, but it just gets your ED staff or your EMS staff a little bit more comfortable. So if you need anything from us,
we do it in small group format, so you can get a workshop together with as many or as few people as you need, and we do it in small groups so that everybody gets some hands-on. For some centers that don't do, or some folks that work with these this population, but not frequently. Like you're not going to run into it very often. So yeah, if you'd like some practice, we'd love to come help.
I think that's a great idea. Be careful what you wish for.
I know, right? We're excited. We like to do this work. It's easier to do like in person because you get that feedback. So I'm sorry. I hope you were able to see some with the Zoom platform here, the camera.
thank you guys. Thank you for dealing with our technical issues.
Thank you. Appreciate it, Cheryl and Dr. Fay. Thank you very much. That was fantastic.
Excellent.
Take
Thank you.
care.
All right. Bye-bye. Okay, so again, we're